to help you pass your exam. And we're talking about testicular cancers today. And we're talking about very fundamental thing about having testicular cancers. And in the testes, I always talk a lot about physiology, but these are very short videos. So recap your physiology, see what a Sertoli cell is, see what Leydig cells are, see what their functions are. So, uh, Sertoli cells support sperm synthesis. Sertoli cells secrete inhibin, and they produce androgen binding protein, which maintains the level of testosterone. And they form the blood testis barrier, and it is the one that produces anti-Mullerian hormone during pregnancy. Well, Leydig cells, on the other hand, are responsible for producing testosterone, and they're the ones that uh, have the axis regulation. Certainly produces inhibin, and FSH is produced from the pituitary. So certainly basically stops FSH production, and it keeps testosterone under control. Whereas FSH will then increase testosterone, like it will come and bind to the Sertoli cell, and LH will bind to the Leydig cell, and LH is for a Leydig cell which produces testosterone, and FSH activates the Sertoli cell which causes sperm production. Now, the thing about testicular cancers are they're very well treatable, and it's almost like a jackpot to get testicular cancers because you can cure those patients. Most, about 80% of them, present in a very early stage. And the way to approach uh, a testicular cancer is that it will present as a testicular mass. And when it presents as a testicular mass, it gets very, so you can see over here, you have a testicular mass, and you can see it, you will have a mass and an ultrasound, and you will do an ultrasound, you will do Doppler, you will see the consistencies of the mass, and you'll evaluate it, and then you can also do an MRI of this mass to study it, and then you get an overview of like the entire case. But what you need to remember is to stage testicular cancers. You need to remember HALO, HALO. So H is hand. You can think of H for hand. Hand has 5 fingers, and 5 fingers means you talk about 5,000, less than 5,000, 5,000 to 50,000, and greater than 50,000 of beta HCG, and we can stage it into S1, S2, and S3 based on the tumor serum markers. So staging based on serum markers will go S1, S2, and S3. If it is less than 5,000, it will be a S1. If it's 5 to 50,000, it will be S2. And if it is greater than 50,000, it will be S3. And S3 is usually worse prognosis, not very hard to. So now we're talking about halo. So H is over. A is what? Alpha fetoprotein. So alpha fetoprotein would 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 be 1. A is the first alphabet. And so less than 1,000, 1,000 to 10,000, greater than 10,000. And L is LDH, so less than 1.5. The upper normal limit 1.5 to 10, and greater than 10. And then after you see the serum markers, you do O, which is orchidectomy. So based on orchidectomy is only when you actually get to get the pathological diagnosis and description of tumors. And when you get the pathological description, you can see if it's limited to the testes, if it has lymphovascular, if it has invaded the spermatic part, or if it needs a scrotum or it has metastatic disease. Now, Once you have the staging done and the workup done, you need to manage these patients. So, in order to manage seminomas, the standard treatment is to see which stage they belong to. So, if they belong to like stage one, which is like confined to the testis without lymphovascular invasion, or without vascular invasion, or it doesn't cause any other problems in stage one, then you put them into either a low risk category or a high risk category. A low risk category would be, like based on the infiltration of the red testis and uh, the other risk factors. Okay, so usually seminoma stage one and higher risk would be seminoma with either like some increase in tumor markers, or you could have like a deeper infiltration into the testis. That's stage one, which is very well confined to the testis. Stage 2A is again here in detail. If you want to understand two, you need to go into 2A and B, which is done according to ESMO. But here you can see 2, PT2, and T3. Okay, and uh, like here you can see the epithelium cell which produces spermatogonia, the ones which are proliferating, and it can invade the epididymis, or it can invade the hilar soft tissue, and then it becomes T2. If it invades the spermatic cord, it becomes T3. So we're talking about 2A here according to ESMO. So what do we mean by 2A? 2A is when there are lymph nodes less than 1 to 2 centimeters. In that case, you have three options. Okay, so basically here what you have is you have testicular mass, a testicular lymph node, like 1 or 2 lymph nodes less than 2 centimeters. And if it is like greater than 2 centimeters, a single lymph node comes in 2D. But this weird situation is the only situation where your lymph node is less than 2 centimeters, where radiotherapy is actually proven to be beneficial. For that reason, you need to know this peculiar case of a testicular mass with single lymph node. That's why stage 2A, you could choose between RT, or you could give BP into 3 cycles, or you could give EP into 4 cycles, or you could observe it as well, but then that would come in some clinical time. But stage one, usually surveillance is recommended. That will be a localized testicular mass. You would go in for surveillance. But stage 2B and 3, you definitely need to give 3 to 4 cycles of EP. And then, despite that, if you still have active lesions, you should repeat the biopsy, because seminoma usually shrinks. But if they don't shrink, that's something you need to consider. So, here is the management of a seminomatous germ cell tumor. Okay. Um. So, if it's like if it's like seminoma in like early stages, it responds very well. But in later stages, it's a little different.